Chapter 6 will cover common injuries to the lower extremity. To begin, I will review the anatomy of the lower extremity to help familiarize you with the structures that are commonly injured. The femur articulates with the pelvis to form the hip joint. The round head of the femur acts as a ball that fits into the acetabulum of the pelvis, or socket. The hip is a very stable articulation that does not have the excessive mobility found in the shoulder. It is surrounded by a strong group of ligaments, including the ligamentum teres, transverse acetabular, iliofemoral, pubofemoral, and inguinal. A strong capsule and large muscle groups on all sides support the joint. These muscles include the hip flexors, hip extensors, abductors, and adductors. The muscles that act on the hip joint and their actions are presented in Table 6-1 on page 113. The muscles of the hip allow for movements of flexion, extension, abduction, adduction, and internal and external rotation. The knee is the largest joint in the body and represents two specific articulations, the tibiofemoral articulation and the patellofemoral articulation. The bones that make up the knee joint include the patella, femur, tibia, and fibula. The femur and tibia are strong bones that support the knee and bear weight. The fibula is the small of the two bones of the lower leg and only bears a small percentage of weight. The patella is encased in a large tendon and slides back and forth in the groove of the distal femur. The motions possible at the knee joint include flexion and extension. A small amount of tibial rotation can also take place at the knee joint. The knee is somewhat unstable based on its shape and unique arrangement. The large femur sits atop the flat tibia. The rounded edge of the femur can roll and slide back and forth on the tibia. The shape of the tibia is improved by the presence of two fibrous cartilages. They are known as the medial and lateral menisci and help reduce joint shock and stress. The four primary ligaments of the knee are the anterior cruciate ligament, or ACL, the posterior cruciate ligament, or the PCL, medial collateral ligament, or MCL, and the lateral collateral ligament, or LCL. The cruciate ligaments arise from the femur and attach to the middle of the tibial plateau. The ligaments are named based on the insertion, anterior and posterior respectively, on the tibia. These ligaments control the anterior and posterior slide of the femur on the tibia. They form an X pattern in which the ligaments cross in the middle of the knee. The MCL helps stabilize the inside of the knee joint. This ligament connects the femur and the tibia. The LCL supports the lateral side of the knee and attaches the femur and the fibula. The shape of the bones and the presence of the menisci and the ligaments all contribute to the static stability. However, this is not enough. The knee relies heavily on the muscles to provide dynamic support. Please see Table 6-2 on page 115 for a list of the muscles that help provide the support to the knee joint. The foot is attached to the lower leg at the talocrural or ankle joint. The tibia, fibula, and talus make up the ankle joint. The true ankle joint allows movement in plantar flexion, or pointing of the toes, and dorsiflexion, or pulling the foot up. However, the ankle is most often injured when the ankle rolls inward and outward. These motions are called inversion and eversion, respectively. The subtalar joint, which is made up of the talus and the calcaneus, allows for these movements. Ligaments that provide support to the ankle joint are found on all sides of the articulation. The medial side of the ankle is much more stable in comparison to the lateral aspect. The deltoid ligament is a broad triangular-shaped ligament that supports the medial ankle. The lateral ankle ligaments include the anterior talofibular, calcaneofibular, and posterior talofibular ligaments. The structure of the ankle is dependent upon the close proximity of the fibula and tibia to give shape to the joint. The anterior and posterior tibiofibular ligaments help hold the ends of the tibia and fibula together. The muscles that act on the ankle joint and help support the foot originate in the lower leg and cross the ankle joint. Please see Table 6-3 on page 116 for a detailed list of muscles that contribute to the movement of the ankle and foot. Each foot has 26 bones, 7 tarsal bones, 5 metatarsals, and 14 phalangeal. It also has 38 individual articulations. The anatomy of the foot is such that it can withstand impact forces twice the body weight. Next, I will discuss injuries that occur to the lower extremity, beginning with the hip. Traumatic fractures to the femur or pelvis are not particularly common in sports. However, they can occur if there is significant force. A vaulting injury in track and field, Falls with equestrian sports or high-velocity direct blows would be the most likely mechanism for a traumatic fracture to the femur or pelvis. A patient with this type of injury would present with significant amounts of pain and have a logical mechanism for fracture. Proper stabilization and immediate transport to a medical facility or evaluation is essential. An open fracture to the femur is also considered a medical emergency and should be treated as such. While commonly thought of as an injury to the lower leg or foot, stress fractures can occur in the hip region to the pelvis or the femoral neck. Stress fractures constitute 10 to 20% of all injuries presented to sport medicine clinics, and 7 to 10% of those affect the femur and pelvis region. This injury is a result of repetitive trauma due to overuse. These stress fractures are common in female distance runners who may have nutritional deficiencies and menstrual irregularities. The athletic trainer must consider the possibility of a stress fracture in patients who fit this profile and have unresolved pain in this area. Adolescents are susceptible to a specific group of injuries to the bony structures at the hip as well. Avulsion fractures can occur when the strong muscles that act to flex the trunk or hip pull away from their bony origin or insertion. Two other injuries to the hip commonly found in children and adolescents that the athletic trainer must be aware of are slipped capital femoral epiphysis, or SCFE, and leg calves Perth disease. An SCFE is a disruption of the growth site of the femoral head. The cause is unknown and can present in either acute or chronic fashion. Leg calf Perth disease is a condition that results in deterioration of the articular surface of the femur at the hip joint. The femoral head can take on a flattened appearance. The mechanism that caused this vascular change is not clearly understood. Regardless of whether either condition is present, a child or adolescent with deep hip pain should be referred to a physician because both conditions, if left untreated, can cause secondary hip problems later in life. A chronic condition that occurs at the bony ends of the pubic bones in the pelvis is called osteitis pubis. The inflammation at the pubic symphysis can be caused by muscle imbalances and repetitive stress. This condition is common to ice hockey players, soccer players, and runners. Chronic pain in the lower abdomen and groin region is often identified by a host of names. Athletic pubalgia, sportsman's groin, and sports hernia are often used to describe persistent groin pain. This diagnosis has been increasingly recognized in the absence of other pathological findings and is thought to be caused by a congenital weakness of the abdominal wall near the groin area. Treatment can include surgical intervention where the abdominal wall is reinforced at the area of weakness. The hip joint is well supported. A deep articulation, strong ligaments, large muscle groups on all sides, and substantial capsule contribute to its stability. Therefore, it is rarely subject to a true sprain injury. However, sprains to the hip joint can occur. A sprain of the hip can occur with a forceful twisting motion, impact, or blow to the hip with the foot firmly planted. Sprain injuries are difficult to grade, first through third. However, sprain injuries to the hip will be painful with all motions. Although also uncommon in sporting events, the hip can be dislocated. When this happens, it will require a significant force. The mechanism of injury is a force transmitted through the femur with the hip flexed, followed by a posterior dislocation. Dislocations of the hip should be considered a medical emergency. The muscles that surround the hip allow for the movement of hip flexion, extension, abduction, adduction, internal rotation, and external rotation. During physical activity, each of these large muscle groups must generate and absorb large amounts of force. When muscle fibers are stretched or incapable of properly absorbing force during activity, they may be subject to strain-type injuries. The thigh is made up of two prominent muscle groups, the quadriceps, which are anterior, and the hamstrings, which are posterior. The primary role of these groups is to extend and flex the knee joint while working together to provide dynamic stability to the knee, particularly when the foot is in contact with the ground. During the course of flexion, extension, and powerful acceleration and deceleration activities, these muscles may be subject to muscle strain injury. These injuries often present with pain, stiffness in the muscle group, discomfort with activity, and weakness. Contusions to the muscle group are often common and hold the potential for complications if they are not treated properly. If left untreated, the pooling of blood caused by the initial injury can cause a formation of a myositis ossificans. Myositis ossificans is a calcium-rich bone-like formation in the muscle, and treatment is based on the limitation caused by the ossification. One of the most common soft tissue injuries to the hip is a contusion called a hip pointer. A hip pointer is a contusion of the top of the iliac crest from a direct blow to the bone. The injury can cause significant pain and loss of function and may require padding once the patient has been cleared to return to activity. Bursitis of the greater trochanteric bursa is a common chronic injury that can cause pain in the hip region. The greater trochanter is a bony projection off the proximal femur where many muscles attach or pass over. The tensor fasciae latae muscle is one of the muscles that passes over this structure, and when it gets tight, it can cause friction over the bony prominence. The bursa's job is to reduce friction between the muscle and the greater trochanter and can become inflamed when there is an increase in friction over the bursa. While acute traumatic fractures to the femur and tibia at the knee joint are not common, they may occur with a significant force. Of particular concern is any fracture that extends through the epiphyseal or growth plate of an adolescent or any fracture that compromises the articular surface. A fracture that extends from the bone into the articular surface is known as an osteochondral fracture. Fractures to the femur, tibia, or fibula can take place with mechanisms commonly associated with sprain injuries. The athletic trainer must take careful precaution to evaluate a patient's level of pain, locations of point tenderness, or any potential deformities when evaluating an acute knee injury. If any of these are present, the patient should have the limb immobilized and be transported for radiographs and complete evaluation. The patella is subject to fracture due to its exposed anterior position and its attachment to the very strong quadriceps and patellar tendons. Patellar fractures occur as a result of a direct blow or with a very forceful contraction of the quadriceps with the lower extremity on an immovable surface, hit from a helmet, direct blow from a bat, or a host of possible situations. Initial care of a suspected fracture should include referral for radiographs and a full evaluation. Osteochondritis dissecans, or OCDs, is a localized separation of a fragment of bone and articular cartilage from the normal bone. This injury is seen following trauma or repetitive injury. Loose bodies float in the joint are called joint mice, which can interfere with normal joint function and will need to be surgically removed. Ligament injuries to the knee are common in sport and physical activity. The four primary ligaments of the knee are the MCL, LCL, ACL, and PCL. The collateral ligaments, the MCL and LCL, primarily provide support to varus and valgus forces, while cruciate ligaments, the ACL and PCL, prevent anterior and posterior translation of the tibia on the femur. Ligament sprain injuries can occur as isolated events, a sprain to one ligament, or in combination, injuries to more than one ligament. The type of force, single plane, rotational, or in combination, determines the ligament injury. Sprains to the MCL take place with the lateral aspect of the knee is hit and resulting valgus force causes the MCL to stretch or rupture. The mechanism of injury for the LCL injury is effectively the opposite of the MCL. The knee receives a blow to the medial aspect, resulting in a varus force that causes the LCL to stretch or rupture. The ACL is usually injured when an athlete is decelerating, plants the foot, externally rotates the femur, and has the knee in a valgus position. This is a classic non-contact ACL injury mechanism. A forced hyperextension of the knee is also a possible mechanism of injury for this ligament. Surgery is recommended for patients who are active. The PCL is often injured with the tibia when the tibia is forced backward. This occurs when the knee is flexed and a force is transmitted through the anterior portion of the tibia. Non-operative treatment of PCL injuries is a commonplace, and many high-level athletes can function without a PCL. Dislocations of the knee are medical emergencies that should be considered limb-threatening. Dislocations of the tibiofemoral articulation are uncommon, however, they can occur in sport. The mechanism of injury involves excessive rotational forces combined with either valgus or varus positioning. The location of the vascular and neurological structures to the lower leg can cause disability to the ankle, which is why immediate critical care attention must be implemented if this type of dislocation occurs. A variety of soft tissue injuries can take place in and about the knee joint. Injuries to the medial and lateral meniscus can happen when the foot is planted in a weight-bearing position and then rotated. The menisci are crescent-shaped fibrocartilage discs that absorb shock to the knee and help give the joint its shape. When the knee is in full flexion, the menisci are compressed between the joint surfaces of the tibia and the femur. This position can put the menisci at greater risk of injury. Signs and symptoms include effusion or swelling in the joint, clicking or snapping, pain going up or down stairs, and joint line pain. Injuries to the medial meniscus are more common than the lateral meniscus due to its anatomical attachment to the MCL. The medial meniscus is more frequently injured in combination with the MCL and ACL, which is called the unhappy triad. Page 127 in your textbook goes into further detail about this condition. Jumper's knee, or patellar tendinopathy, is an overused chronic condition that is seen frequently in jumping sports such as basketball and volleyball. The patellar tendon serves to insert the large quadriceps tendon and slides through the groove of the femur. An individual with weakness in the quadriceps who cannot absorb forces of jumping and landing is at risk for patellar tendinitis. The injury is also seen in individuals with tightness and poor flexibility. Initial care includes modification of activities, treatment for discomfort, and rehabilitation to improve strength and flexibility. In adolescent patients, anterior knee pain and discomfort of the patellar tendon may be due to Osgood-Schlatter's disease, or Sinding-Larsen-Johansson disease. Disease is a bit of a misnomer because both diseases are orthopedic conditions that cause anterior knee pain and are common in growing patients. Osgood-Schlatter is an apophysitis that results in excess bone formation and an increase in size of the tibial tuberosity due to increased tension at the insertion of the patellar tendon. Sinding-Larsen-Johansson disease is a painful inflammation at the inferior pole of the patella. Treatment of both includes modification of activities and careful strengthening and stretching of the surrounding musculature. The prepatellar bursa sits on the anterior aspect of the patella. This bursa, when not inflamed, is quite thin and not noticeable. However, if the knee is contused on a hard surface, the bursa can become inflamed and cause significant swelling. Chronic bursitis can also be found in and around the knee joint. Two common chronic injuries include suprapatellar bursitis and pes anserine bursitis. Bursitis is caused by repetition changes, changes in workout volume or intensity, or mechanical changes due to weakness and inflexibility. Neurovascular injuries to the knee are not common, and if they do occur, they are often associated with trauma such as contusions, fractures, or complete knee dislocations. It is worth knowing that the peroneal nerve resides in a very superficial location, at the fibular head, and is susceptible to trauma. This nerve can be easily contused, irritated secondary to taping, or compressed. Injury to this nerve can cause compromise to dorsiflexion and inversion of the ankle, which is why return of normal strength and sensation is important in the return to activity decision. The patellofemoral articulation is a distinct joint that sits above the tibiofemoral articulation. The patella is a wedge-shaped sesamoid bone that sits in the groove created at the distal end of the femur. The strong quadricep muscles serve to stabilize the patella as it passes through the groove during flexion and extension of the knee. These muscles act as dynamic stabilizers to the patella as the knee moves from extension, where the patella is most mobile, to flexion, where the patella sits deeper in the femoral groove. Common injuries and conditions to the patellofemoral joint include patellofemoral stress syndrome, or PFSS, subluxation of the patella, and dislocation of the patella. PFSS is a generic term for pain underneath and/or on top of the patella resulting from physical and biomechanical changes in the patellofemoral joint. It is also commonly referred to as patellofemoral pain syndrome, or PFPS. Subluxation occurs when the patella is pulled laterally during a quadriceps contraction or an extended knee and partially moves from the femoral groove. Repeated subluxations will result in damage to the articular surfaces and cause pain. Progressive instability of the patella may lead to a full dislocation. A dislocation occurs when the patella moves laterally and comes to rest outside the femoral groove. A dislocated patella will cause significant soft tissue disruption on the medial aspect of the knee. Treatment of any of these injuries includes addressing acute inflammation, addressing muscular weakness, tightness of the static structures, and biomechanical insufficiencies. There are some specific injuries to the lower leg that the athletic trainer must be able to identify and properly refer. These include muscle strains, chronic tendinitis, stress fractures, and compartment syndromes. The nature of these injuries is often sport-specific. The gastrocnemius or calf muscle, anterior tibialis, peroneals, and posterior tibialis are commonly strained in the lower leg. Medial tibial stress syndrome, also referred to as shin splints, is classified as a strain to the posterior tibialis muscle, and details about this pathology can be found on page 130 in your textbook. These injuries often present with pain, stiffness to the muscle group, discomfort with activity, and weakness. Tendinitis occurs in many of the tendons of the muscles previously listed. Like all overuse tendinitis problems, change in intensity and frequency of activity are common causes of these injuries. Biomechanical alterations due to foot position, muscle weakness, or lack of flexibility are common factors contributing to tendinitis. Tendon ruptures, especially to the Achilles tendon in the lower leg, are common injuries in sport. The injury rate increases with age, making this a more common injury among middle-aged recreational athletes when compared with their younger counterparts. Sudden forceful plantar flexion movements can cause these injuries, with signs and symptoms including painful sensation in the tendon followed by an audible pop. Prompt referral to a physician is essential, and surgical repair is required for a complete tendon rupture. Stress fractures can occur to the lower leg and are common in repetitive impact sport activities. Running is the most common sport activity that can lead to stress reaction in the bones of the lower leg. Skeletal differences, variations in gait, poor running conditions, hard surfaces, prior injury, and poor training techniques are common causes of stress fractures. Signs and symptoms include pain with activity that does not change after the athlete has warmed up, pain at night, and very localized pain. A patient who has signs and symptoms of a stress fracture should be referred to the physician for further evaluation. Compartment syndromes are injuries that involve an increased pressure that is localized to a specific compartment of the lower leg. Compartment syndromes cause compression of neurovascular structures and, if left unattended, can lead to tissue death. An acute compartment syndrome secondary to trauma, such as being kicked, should be considered a medical emergency. Chronic compartment syndrome will present signs and symptoms during or at the end of physical activities. Signs and symptoms include pain, tightness and swelling of the tissue, shiny appearance to the skin, reduced circulation of the foot, decreased sensation to the foot, and absence of or weakness in the dorsiflexion of the ankle. If the injury does not respond to conservative treatment, surgical intervention may be necessary to relieve the symptoms. The ankle and foot may be fractured from the injury mechanisms similar to those found with ankle sprains. The same mechanism of injury that may produce a sprain to the lateral ankle ligaments can also cause a fracture to the medial malleolus of the distal tibia. Likewise, an eversion mechanism can cause a sprain to the medial ligaments or a possible fracture to the lateral malleolus of the distal fibula. Avulsion fractures in the ankle take place when a piece of bone is pulled off with the ligament. Avulsion fractures can also occur at the insertion at the base of the fifth metatarsal. The distal fibula and tibia may also be fractured when inversion or eversion mechanisms of injury are combined with rotation. There are some fractures that are specific to the foot. A Jones fracture is a fracture at the proximal third of the fifth metatarsal of the foot, where two of the three peroneal muscles attach. This location has a poor blood supply and may have an extended healing period that may require surgery if the bones have been separated. Stress fractures to the foot are frequent injuries among athletes who participate in impact loading activities. A stress fracture to the metatarsals, most often to the second metatarsal, is also called a March fracture. Poor or ill-fitting footwear, skeletal differences, variations in gait, hard surfaces, prior injury, and poor training techniques are common causes of stress fractures. Traumatic or repeated injuries to the ankle can make the joint susceptible to osteochondral lesions. If the upper part of the talus or the talar dome is compressed against the joint surface of the tibia, a compression fracture to the chondral surface can occur. Repetitive trauma to the joint surface can result in OCD lesions, much like those discussed in the knee. The Lisfranc joint is the joint between the 5 metatarsal bones and the mid-tarsal bones, which include the 3 cuneiforms and the cuboid. Injury to this area may occur from a direct crushing mechanism of injury to the midfoot region. The result is a large force crossing the ligament and capsule of the tarsometatarsal joints. Diagnosis of this injury is often found by radiographs, and treatment is based on symptomatic care, of which the most common symptom is pain with weight bearing. The ankle sprain is the most common injury that occurs in sport and physical activity. Inversion sprains can often take place in combination with plantar flexion. This mechanism of injury is common and can take place when someone lands on his or her foot, steps off a curb, or steps in a hole. An inversion plantar flexion mechanism will usually cause damage to the anterior talofibular ligament. A true inversion mechanism can cause damage to one or more of the 3 lateral ankle ligaments, which include the anterior talofibular, calcaneofibular, and posterior talofibular ligaments. Eversion injuries stretch or rupture the triangular deltoid ligament located on the medial aspect of the ankle. Similar to muscle strains, ligament sprains are graded based on severity, 1st through 3rd. An injury to the ligaments that hold the distal tibia and fibula together is called a high ankle sprain or syndesmotic sprain. Dorsiflexion and forced external rotation are common mechanisms for this injury. The syndesmosis that is injured as a result of the mechanism is made up of the anterior and posterior tibiofibular ligaments and the interosseous membrane. These injuries should be evaluated with care since they are often associated with fractures. High ankle sprains frequently take a longer period of time to recover when compared to other common ankle injuries. As previously noted, inversion ankle sprains are particularly common. An inversion sprain may result in an increased thickening of the synovium along the anterolateral aspect of the ankle joint. This inflammation of the joint lining can cause the tissue to thicken, making it susceptible to entrapment in the joint. This condition is known as anterolateral ankle impingement. As the talus fits snugly into the ankle joint in full dorsiflexion, this condition causes pain for the patient and is also commonly seen in patients with chronic ankle instability. Plantar fasciitis is an inflammation of the broad band of fascia that extends from the calcaneus to the front of the foot on the plantar surface. Overuse, rapid changes in intensity, and frequency of workouts and biomechanical alterations are underlying factors. Signs and symptoms include pain in the heel or on the bottom of the foot that is worse in the morning. Care of plantar fasciitis includes treatment to decrease pain, therapeutic exercise to increase flexibility, soft tissue massage to improve tissue mobility, in addition to correcting any biomechanical issues, including proper footwear. Inflammation of the metatarsophalangeal joint of the great toe can result from a sprain-type mechanism or repetitive trauma due to hyperextension, also known as turf toe. Despite its name, it is also common to court sport athletes or anyone who exercises on hard surfaces. Signs and symptoms include pain, swelling, point tenderness at the base of the great toe, and pain with hyperextension. Shoes with a stiff forefoot that limit hyperextension can help alleviate some of the discomfort and potentially provide relief from turf toe. Taping is also a temporary intervention to alleviate discomfort. In the distal portion of the foot, there are nerves that sit between the metatarsals and the metatarsal heads. When these nerves become irritated due to pressure from repeated extension of the toes or from compression due to poorly fitting footwear. Localized swelling found between the metatarsal heads is called a neuroma, and specifically when the pain is between metatarsal heads 3 and 4, it is referred to as a Morton's neuroma. Signs and symptoms include pain, numbness, and point tenderness between the metatarsal heads, and increased pain when squeezing the metatarsal heads. Treatment involves improving the fit of shoes, decreasing inflammation, and the use of a pad to help relieve pressure in the area. In the area behind the medial malleolus, inferior to the soft tissue and bones below it, lies the tarsal tunnel. The tendons of the posterior tibialis, flexor hallucis, and flexor digitorum run through the tarsal tunnel. Alongside these tendons, you will find the tibial nerve and tibial artery. When the area around these structures becomes inflamed, numbness and tingling to the plantar surface of the foot can occur, which is referred to as tarsal tunnel syndrome. Persistent tarsal tunnel inflammation can lead to muscle weakness and atrophy. A normal course of treatment involves reducing the inflammation to relieve pressure on the tibial nerve. The injuries presented in this chapter represent an overview of the common conditions the athletic trainer may see in the lower extremity. The injuries outlined represent only a fraction of the possible injuries with which the athletic trainer must be familiar. The athletic trainer's ability to evaluate, provide initial care, and properly refer, treat, and rehabilitate a wide variety of injuries and conditions is rooted in his or her education, preparation, and dedication to learning well beyond his or her certification. Students pursuing a degree in athletic training must be committed to establishing a strong academic foundation from which they can build their allied health career.